All right, thank you everyone for joining us and welcome to Cancer Research Institute's webinar series, Breakthroughs in Cancer Immunotherapy. Today's date is Thursday, June 10th, 2014. The topic for today's webinar is Immunotherapies for Prostate, Bladder, and Kidney Cancers. I'd like to first acknowledge generous support from our sponsor, Dendreon Corporation. Dendreon is a biotechnology company whose mission is to target cancer and transform lives through the discovery, development, commercialization, and manufacturing of novel therapeutics. The company applies its expertise in antigen identification, engineering, and cell processing to produce active cellular immunotherapy product candidates designed to stimulate an immune response in a variety of tumor types. Thank you, Dendreon, for your support. My name is Brian Brewer, and I'm Director of Marketing and Communications at the Cancer Research Institute. Cancer Research Institute is the world's only nonprofit organization devoted exclusively to harnessing the immune system's power to conquer all types of cancer. We fund scientists around the world whose work has led to significant breakthroughs in treating cancer with immunotherapy. Over the next 45 minutes, you'll have an opportunity to hear firsthand from an immunotherapy expert how cancer treatment today is undergoing a revolution thanks to these breakthroughs. After a 25-minute presentation from our speaker, we will open the discussion up to questions submitted by you. You can pose your question at any time throughout the presentation by typing in the Q&A box on your screen. Today's webinar is being recorded and will be made available for viewing on the Cancer Research Institute website and on our YouTube channel. Now it's my pleasure to welcome today's expert speaker. Dr. Sumit Subudhi is a clinical advanced scholar instructor at the University of Texas MD Anderson Cancer Center in Houston, where he currently investigates novel immunotherapeutic strategies in prostate cancer. His training and work over the years have put him at the epicenter of significant advances in cancer immunotherapy, including the areas of checkpoint blockade therapy and vaccines. His research today focuses on investigating how androgen receptor pathway signaling influences T-cell activation, differentiation, and migration to tumor sites. Now it's my pleasure, Dr. Subudhi, thank you for joining us today.
Thank you, Brian, and CRI and Dendreon for allowing me to speak of immunotherapy strategies in genitourinary malignancies. There's been some exciting developments and recent data that's been presented at our American Society of Clinical Oncology conference this past week, and I'll be presenting some of that data today. So why immunotherapy? We know that immunotherapy can be successful because it can kill cancer cells by taking advantage of three different properties of the immune system: adaptability, specificity, and memory. And as a result, it can lead to durable or even curative responses, which is something that's not seen with chemotherapies, anti-angiogenic therapies, or even small molecule inhibitors of molecular pathways. So rationale for developing immunotherapies as a treatment for cancer is that we see expression of tumor antigens, such as cancer testis antigens, for example, NeoCISA-1, that can be recognized by T cells. NeoCISA-1 is expressed by a number of tumor cell types, including bladder. In addition, there's an association of tumor-infiltrating lymphocytes within the tumor microenvironment that correlates with good prognosis. And that means the patients with higher number of TILs tend to survive longer. And this has been seen in bladder cancer, as I'll show now. So what you can see here in the, let me get this arrow over here. In the left panel, in A, here's a patient whose bladder cancer has low number or low frequency of TILs, whereas a different patient has a high frequency of TILs within the tumor microenvironment of the bladder. And in the bottom graph, what we see is, on the y-axis is probability of survival, and on the x-axis is time in day. And what we find is that patients with high-risk bladder cancer with high frequency of TILs live significantly longer, as shown here in this green line, compared to those with low frequency of TILs in the red line. So one of the goals of immunotherapies is to improve the tumor microenvironment by increasing the number of TILs. And the way we've gone about this is by using cytokines, bacterial stimulants, vaccines, adoptive cellular immunotherapy, which I will not speak about today since this has been more the focus of hematological malignancies, as well as targeting immune checkpoints. Now, we've been doing immunotherapy since the 1890s. However, we've been largely unsuccessful. And we believe that one of the reasons why we've been unsuccessful is because our lack of understanding of how T cells are regulated within the tumor microenvironment. And since the 1980s, we've learned that there are positive and negative signals that actually govern T cell responses within the tumor microenvironment. So what you see in the left graph is you have a T cell with its T cell receptor interacting with tumor antigen expressed on a tumor cell or an epithelial cell. This leads to signal 1. Signal 1 would be analogous to putting a key in a car ignition and turning on the ignition. The motor starts, but the car doesn't move. So with signal 1 alone, the T cell does not proliferate. It actually needs a second signal, and that's shown in this second graph or panel, where signal 2 is given by a professional antigen presenting cell, such as a dendritic cell, macrophage, or even B cell. The combination of signal 1 and signal 2 leads to T cell proliferation. Again, analogous to putting the accelerator on a car. So signal 1 is the car key in the ignition that's turned on, and signal 2 is putting the accelerator on the car, and the car begins to move. Now, if we only had these two signals for T cells, then you can imagine that every time we had an infectious disease, we would then die from a lymphoproliferative disorder. So there has to be a way of maintaining homeostasis or stopping the car. And this we know from work by Jeffrey Bluestone and James Allison is governed by CTLA-4, shown in red. So CTLA-4 is a protein upregulated on T cells and provides the brakes on the T cells, thus attenuating the response and leading to homeostasis. What Jim Allison then did was he developed an antibody against CTLA-4. And this transiently removes the brakes from the T cells, allowing it to be activated for a longer period of time. He then showed that when you treat tumor-bearing mice with anti-CTLA-4, these mice were cured of their cancer. This was finally translated into the clinic, and the data I'm going to show you is from metastatic melanoma, where patients were treated with anti-CTLA-4 alone or in combination with a GP100 vaccine, and compared to GP100 vaccine alone, which is shown right here. And what you can see is that patients that received anti-CTLA-4 or ipilimumab shifted the curve to the right, showing that there's a benefit in overall survival. But even more striking is that about 15 to 20% of the patients received long-term durable responses lasting greater than 5 years. So now when we think about genitourinary cancers such as bladder cancer, kidney cancer, and prostate cancer, where are we now in terms of immunotherapies? So in kidney cancer, we have cytokines that are FDA approved, IL-2 and interferon alpha. In bladder cancer, at least for superficial bladder cancer, we have a bacterial stimulant known as BCG. And for prostate cancer, we have vaccines such as sipuleucel-T, which was FDA approved over the last 3 to 4 years. Now let's talk about cytokines. For example, IL-2. In 1985, it was considered a cancer breakthrough of the year in Fortune magazine. How do cytokines work? Well, IL-2 stimulates a set of T cells known as CD8 T cells or cytotoxic lymphocytes, CTLs, as well as NK cells or natural killer cells, that will then kill tumor cells. In addition, we have interferons, interferon alpha and beta, that increases MHC, or major histocompatibility complex class 1 expression. What this does, it allows the tumor cells to express more tumor antigens that can be recognized by T cells. In addition, the interferons actually inhibit tumor cell proliferation. So it works in two ways. We look at the timeline of treatment or successful treatments in kidney cancer. We find that IL-2 and interferon were first tested in the early 1980s. And then high-dose IL-2 was FDA approved for kidney cancer based on phase 2 data demonstrating a progression-free survival for patients treated with kidney cancer. However, the 1990s was all about anti-angiogenic agents as well as tyrosine kinase inhibitors that have been largely successful in kidney cancer. And then more recently, the combination of an anti-angiogenic agent known as bevacizumab, or an anti-VEGF receptor antibody, combined with interferon alpha, was FDA approved for kidney cancer. So this is a chart that looks at systemic treatments for clear cell cancer. And what you can see based on phase 3 data and based on phase 3 data, you can see that bevacizumab plus interferon alpha is first-line therapy for patients with good or intermediate risk kidney cancer. But an alternative first-line therapy is also high-dose IL-2. So this is data showing 255 patients that were treated with high-dose IL-2. And you can see 17 of the 255 patients, which accounts for about 6% of the patients, were complete responders in the green line, and they had durable responses lasting for years. And then approximately another 6% of patients in the yellow line had partial responses. However, if we look at all the phase 3 trials that looked at interferon or IL-2 as a monotherapy or even in combinations, you can see the response rates range anywhere from 3% to 21%, not very high. But the most troubling thing is that there was no survival benefit in any of these phase 3 trials. And then when we look at the most recent trial of comparing interferon alone with interferon plus bevacizumab, what we find is that there is a significant benefit in progression-free survival, but no benefit in overall survival. So basically, what we see with cytokines is that a subset of patients are responding, approximately 6%, and but the population as a whole of kidney cancer patients are not achieving any durable benefits. Now, if we look at the way drugs are currently approved by the FDA, you have a drug on the, let me get the arrow here. You have a control drug right here shown in purple, and it's compared with a drug that's effective in blue. And you can see that the drug that's shown by the blue curve increases overall survival by shifting the curve to the right. But as you can see, almost all the patients will actually die from their cancer. And so the current treatments, whether it's chemotherapies, anti-angiogenic agents, or even targeted therapies such as small molecule inhibitors, none of them actually cure patients. But what we've seen with anti-CTLA-4 is that not only do we shift the curve to the right, but we also lift the curve right here, where a subset of patients are actually achieving durable or even curative responses. But unfortunately, it's a small subset. As I've shown you with the melanoma data, it was anywhere from 10 to 20% of the patients. The question is, can we actually improve upon this? And what you see is, this is the notion we have. If we combine immunotherapies with other therapies, we can potentially raise the curve so that a lot more patients are achieving durable or curative responses. So what you see in this phylogenetic tree here is that CTLA-4, which is one of the immune checkpoints that we've been targeting already, has other family members, such as the PD-1 and PD-L1 pathway here. And there's been recent data showing that this pathway is also a promising pathway to target in genitourinary malignancies. And I'll show you data for that. What I'm going to first show is that when we target the PD-1 pathway with nivolumab and anti-CTLA-4 or CTLA-4 with ipilimumab in advanced melanoma patients, we see dramatic responses. In the top graph here is a spider plot that shows the change in a target lesion from baseline, and on the x-axis is weeks in treatment since treatment initiation. And each line represents an individual patient, and here's the zero line showing zero change, whereas minus 100% means the patient was cured. And what you see is that a significant number of patients either have stable disease or significant regression in their tumors, lasting for quite some time. What you have in this bottom plot is a waterfall plot where each bar represents an individual patient, and on the y-axis you're looking at change in target lesion from baseline. And what you see is that majority of patients have downward arrows, because here's a 0 point right here. And that shows that greater than 50% of patients are responding to the combination of targeting PD-1 and CTLA-4 pathways. And what's even more striking is the survival data that shows that 1 year survival, 82% of patients are surviving. And again, I want to remind you, this is advanced melanoma. So this data led to Science magazine considering cancer immunotherapy as a breakthrough of the year in 2013. So we've come a long way since 1985, where cytokines such as IL-2 was considered cancer breakthrough. So at ASCO 2014, which was last week, the Hammers group presented phase 1 data looking at targeting PD-1 in combination with targeting CTLA-4 in metastatic renal cell cancer. And when you look at these waterfall plots, you can see a significant number of patients are responding to the combination of both targeting CTLA-4 and PD-1. And this is exciting, and we're looking forward to looking at what the survival data looks like a year from now. Now moving on to bladder cancer. So in bladder cancer, they've been using bacterial products as cancer immunotherapy. Where was this concept developed? It was developed in the 1890s by William Coley, a surgeon. He developed a Coley's toxin that he injected into patients with sarcomas, and this toxin consisted of Streptococcus pyogenes. And he was able to cure his first patient in 1891. And it wasn't until the 1950s when we found out that this toxin actually had TNF-alpha in it. William Coley treated several patients with this, and this is reviewed in Nature in 1992. And what we find is that most of his patients were sarcoma patients. But what you see, he treated a total of 104 patients, and about 1/5 of them had responses, durable responses lasting greater than 20 years. Should point out that he also treated some kidney cancer patients, and 1 out of 6 had durable responses lasting greater than 20 years. So BCG is a standard treatment for patients with superficial bladder cancer, and it helps prevent recurrence. And we've been using this since the 1970s. However, we haven't had much progress since then. But what we have learned is how it works. From laboratory experience, we know that BCG recruits a lot of inflammatory cells like polymononuclear cells, as well as macrophages, which then help release the cytokines that recruit T cells to the tumor microenvironment. And then these T cells release more cytokines that help aid in tumor cell death. So I want to show you a trial that's being proposed by the SWA group and being the lead center being in San Antonio. In this trial, what they're trying to do is improve T cell priming with intradermal BCG vaccine to be given with the intravesical BCG. So what's happening is they're taking patients with superficial bladder cancer, giving them a PPD test, and then those that are PPD negative are randomized to receive either the vaccine, the BCG intradermal vaccine, or placebo vaccine. Then patients in both groups will go on to receive intravesical BCG induction, which is a standard of care. And then patients will be biopsied 6 weeks later to look at responses. But currently, treatments for patients with lethal or metastatic bladder cancer are limited to chemotherapies that have been successful. And there is no proven second-line therapy that improves overall survival. But what we found is that when you target PD-L1 in patients with metastatic bladder cancer, as presented in ASCO by the PALS group, and when you look at the spider plots, where on the y-axis you look at the change in sum of longest diameters from baseline, and on the x-axis is time on study, you can see that there's a significant number of patients that have complete responses, that have partial responses in green, 2 patients with complete responses in black, and then a number of patients with stable disease, and that's shown in blue. And the patients that progressed are shown in red. So we believe that immunotherapies, especially in the form of targeting the immune checkpoints, are valuable tools in both renal cell and bladder cancer, and we're hoping to see long-term survival data over the next year or 2. Now I'm going to move to prostate cancer. This is a clinical states model of prostate cancer developed by Howard Scher and Glenn Heller at the Memorial Sloan Kettering Cancer Center. And what you see on the left-hand side is non-castrate prostate cancer that can be divided into clinically localized disease, rising PSA, and clinical metastases. I should point out the standard of care for clinically localized disease is either radiation therapy or surgical therapy for curative intent. However, 20% of patients will eventually recur and will either be a rising PSA or have clinical metastases. And at this point, the standard therapy is the same therapy that we've had since the 1940s, which is castration therapy to lower testosterone levels. However, this is not curative, and at some point, the prostate cancer will learn how to live in this low testosterone environment and will become castration resistant. Once the prostate cancer becomes castration resistant, the patient is more likely to die from prostate cancer than any other comorbidity they have. And as you can see, as of 2004, there's only one therapy to improve overall survival in prostate cancer, and that is docetaxel. And that therefore created 2 clinical bins that we call pre-docetaxel and post-docetaxel, in which drug development occurred. And then more recently, as you can see, we have 5 new agents that have been successful in castration-resistant prostate cancer in phase 3 trials showing overall survival advantage. However, I should point out none of these are curative, so we have a long ways to go despite having so many new therapies in prostate cancer. One of the therapies is sipuleucel-T, which is a cancer immunotherapy vaccine. So cancer vaccines, how they work? Well, they activate the immune system by generating specific and targeted immune responses. There's two types I'm going to talk about today. There are many others, but the one I'm going to talk about is autologous dendritic cell based, and the other one is vector based. So autologous dendritic cell based vaccine is what we see with sipuleucel-T Provenge. Let me see if I can get my arrow to work. Apologize, I cannot get my arrow to work, but we can see the left-hand panel is a patient whose blood is being leukapheresed, and that's shown in the top panel. Oh, thank you. Top panel here. And then these leukapheresed cells are collected and cultured in vitro so that antigen presenting cells are only cultured. Then what happens is a chimeric protein that is a combination of GM-CSF, which is a cytokine that leads to antigen presenting cell activation, as well as PAP, which is prostatic acid phosphatase, which is a tumor-associated antigen for prostate cancer. This chimeric protein is cultured with the antigen presenting cells so that these antigen presenting cells take it up, get activated, express activation markers, but also present the PAP on their surface. These antigen presenting cells are then reinfused into the patient, and then once reinfused, these antigen presenting cells then activate T cells. These activated T cells then go on, proliferate, and then go kill the cancer cells. And that's how sipuleucel-T works. And so what I'm going to show you now is Phil Kantoff's group at Dana-Farber showed in a multi-center phase 3 trial that sipuleucel-T actually improves overall survival. And so what you can see here in blue are patients treated with sipuleucel-T, and the control arm is in red here, and you can see that there is an improvement in overall survival. Only thing that's a bit surprising is that we don't see that tail at the end. And what they do here is they take a vaccinia or tumor cell viral proliferate, infect epithelial cells, which will cause its necrosis. And then once it's necrosed, antigen presenting cells will take up the cellular debris, and then will present PSA antigen as well as these co-stimulatory molecules, which will then go on to help the T cells attack the cancer cell. And what we see here is randomized phase 2 data, which is impressive, but it shows that this vaccine improves overall survival when compared to control group, and right now, phase 3 trials are ongoing. So now I want to present a phase 3 trial in which ipilimumab, or anti-CTLA-4, plus radiation therapy was combined in patients with castration-resistant prostate cancer. This was presented in ESMO 2013 in October. And here's a trial schema. Here we see that patients were treated with either placebo or ipilimumab after receiving radiation therapy in both arms. And what we see in a subset of patients, if you look at a CAT scan looking at their prostate, which is infiltrated by a significant amount of tumor, this is at the time of screening, But you can see 14 months later, there's absolutely no evidence of tumor present. So definitely a subset of patients benefited from this treatment. However, if we look at overall survival analysis, we can see looking at the median survival right here, there's no difference whether a patient received ipilimumab, which is in blue, or placebo. The other thing I'd like to point out is that it looks like a subset of patients may have actually been harmed by ipilimumab here. So then when a pre-specified subgroup analysis was performed, where we look at various clinical characteristics of the patient as well as laboratory values at baseline of the patients, we see that many of them favor ipilimumab, as shown in this rectangle here. However, one of them, visceral metastases, which is metastases to the metastases to the liver or to the lung, favors placebo. So another subgroup analysis was done, which is hypothesis generating, where patients in this trial were only analyzed with those that had favorable clinical characteristics and no visceral metastases. And what we can see in this subgroup analysis, which I have to say is only hypothesis generating, suggests that ipilimumab can benefit a subset of patients by improving overall survival as well as curative responses. The question is, can we combine ipilimumab with some other therapy to enhance its responses in these subset of patients? And we believe targeting the androgen receptor pathway is one way of approaching this. So what you see here is when you target androgen receptor pathway, you see infiltration of lymphocytes not only into the normal prostate tissue, but also to the treated prostate. To the prostate cancer itself. So there are many ways of targeting the androgen receptor. One is just by androgen synthesis itself. And you can see that you can just surgically castrate men, or you could target the GnRH pathway on top that affects that works either as agonist or antagonist that leads to lower testosterone levels. Or you can target the adrenal glands here with either ketoconazole or abiraterone acetate. These are all ways to inhibit androgen synthesis. However, Charles Sawyer's lab, back when he was at UCLA and now at Memorial Sloan Kettering Cancer Center, developed other ways of targeting the androgen receptor pathway by blocking the androgen receptor itself. So what you see here is a schema of the prostate tumor itself with androgen receptors here that normally bind to DHT, a potent form of testosterone. And once an androgen receptor binds to DHT, it then translocates into the nucleus to allow the prostate cancer to grow. So Charles Sawyer developed the drug MDV-3100 that binds to the androgen receptor and prevents it from binding to DHT, and therefore the androgen receptors stays in the cytoplasm. This drug is also known as enzalutamide and is FDA approved for castration-resistant prostate cancer. Another drug that he's developed is also ARN-509, which is a sister drug to enzalutamide. So what we've done here at MD Anderson Cancer Center is we've treated patients with castration-resistant prostate cancer. And what you're looking here on the y-axis are patients' changes in PSA once they're treated with abiraterone acetate, which is an androgen synthesis inhibitor, as I mentioned before. And you're looking at changes in PSA, and here's 0. And here in blue are patients who have PSAs that have actually increased while on treatment, whereas those in red and tan are ones that had decreases. And you can see about 50% of patients have significant decreases in PSA with monotherapy of abiraterone acetate. If you treat the same patient population, so different patients, with enzalutamide alone, you see a similar trend where about 50% of patients are responding to the monotherapy. However, if you combine both, what you see is that you really dichotomize patients and into ones that are responsive to targeting the androgen receptor pathway and those who are not in blue. So what we're doing here is we're proposing a trial that should be opening up in the next 6 to 12 months, where we take patients with metastatic castrate-resistant prostate cancer, treat them with a combination of ARN-509 and abiraterone acetate for 8 weeks to optimally block the androgen receptor signaling pathway. And then we'll divide them into AR-sensitive group and AR-resistant group. And we'll then take that AR-sensitive group and divide them into 2 arms. Both arms will receive the combination of ARN-509 and abiraterone acetate, but arm B will also receive ipilimumab or anti-CTLA-4 for 4 doses. And we believe this subset of patients will probably, or we hypothesize, will have long-term durable and curative responses with targeting the immune checkpoint. Another trial that we're doing with UCSF is taking sipuleucel-T, which is a cancer vaccine for prostate cancer, and combining it with ipilimumab. And we have 2 arms where patients are being randomized, where they either get ipilimumab right away, concurrently with sipuleucel-T, or they get it delayed or sequentially with sipuleucel-T. So that concludes my talk about current therapies and approaches with in the genitourinary malignancies. But what I want to present now are some of the challenges and limitations of immunotherapies in these cancers. One, subset of patients benefit, and we have to try to find combinations where a significant more portion of patients will derive durable and curative responses. Number 2, there's a unique set of toxicities that seem to be associated with them, especially when you're targeting the immune checkpoints. And these are known as immune-related adverse events. And they're thought to be similar to autoimmune diseases, with the difference being that they're transient and they're reversible by stopping the therapy as well as providing immunosuppressive agents such as steroids. 3, measuring disease burden and treatment responses can be a challenge in these with these immunotherapies, and therefore, instead of having the typical RECIST criteria or the WHO criteria for measuring responses, Jed Walchuk's group at Memorial Sloan Kettering has developed something called the immune-related response criteria. And I'll show you that in the next slide. So here, this is a melanoma patient that was treated with anti-CTLA-4, and you can see his screening tumor burden, which was quite significant on the skin, but you can also see it on the CAT scan as well. And then 12 weeks after being treated with anti-CTLA-4, you can see that tumor burden has actually increased, okay? And so the patient was taken off drugs and placed into hospice because it was thought that he was progressing on disease. However, with no further therapies, 4 weeks later, you can see that his cancer is regressing. And then 72 weeks after initiating treatment, you can see that his cancer is disappearing and he's having an ongoing durable response. So why is there an initial increase? Well, in a subset of patients, it's believed that targeting the immune checkpoints leads to increased immune infiltrates within the tumor that causes the cancer to look like it's growing more before you start seeing these durable and ongoing responses. So looking into the future, as you can see, there's several targets that we can start thinking about or already being thought about now and are being tested in the clinic. Here's PD-1, as I mentioned earlier, and CTLA-4 and PD-L1. I've shown you data on these 3, but you can see there's a number of other targets that are being studied at major institutions as well as by the pharmaceutical companies. And I'd like to acknowledge my research mentor, James Allison, who is instrumental in bringing immune checkpoint targeting from the laboratory bench into the clinic. And team at MD Anderson. Thank you.
Thank you very much, Dr. Subudhi, for that excellent presentation. It's exciting to hear that there's been a lot of progress in identifying and developing immune-based treatments for kidney, bladder, and prostate cancer. With Father's Day just around the corner, it's this Sunday here in the United States and elsewhere, it's top of mind for a lot of folks out there who have a loved one who may be dealing with prostate cancer or one of the other cancers you described. So thanks for that. So we do have some questions from the viewers that I would like to share with you. The first one gastric non-resistant cancers. And I guess the question is, what biologically is different? Why do some men's cancers become castration resistant?
Okay. So it turns out that given enough time, all men's cancers will become castration resistant. And the reason for that is that targeting the androgen receptor pathway itself is not sufficient to cure a patient. And basically, the cancer mutates either by one mechanism is increasing the number of androgen receptors it has so that it can learn to live in such a low testosterone environment, or creates other pathways such as the PI3 kinase pathway and learns to live in this low testosterone environment. So basically, mutations or the genetic instability of cancers, with time, all of them will progress to castration-resistant prostate cancer. So one of the goals that the prostate community is doing now is moving drugs like sipuleucel-T or ipilimumab into the castration-sensitive setting in order to prevent or to cure the disease before it progresses into its lethal form.
Yeah, I was very interested in the study that you mentioned, combining sipuleucel-T with ipilimumab. Do you have any sense of when the data from that study will become public?
Yeah, we plan on actually opening that study next month. So that's where it just got IRB approved, and so we should be enrolling shortly.
Yeah, that will be great, and hopefully we'll see with that long tail that you were talking about in patients who do respond to checkpoint blockade therapy. We'd love to see that certainly in the prostate cancer populations, but as well the other cancer types as well. I have another question about improving overall survival with sipuleucel-T. Are there, aside from combining with checkpoint blockade, are there other strategies that you're aware of? Are they looking at perhaps identifying other prostate cancer antigens that can be incorporated into their product?
Yeah, that's a great question. I'm not sure what Dendreon themselves are doing, but I can tell you that both Memorial Sloan Kettering and MD Anderson are trying to find neoantigens that are expressed by the prostate cancer to identify them and figure out which ones are the immunodominant ones, and using those in the future as vaccine strategies. Right now, what we're doing is we know many tumor-associated antigens, such as prostate-specific antigen, or PSMA, which is prostate-specific membrane antigen, and what Dendreon has done is PAP, or prostatic acid phosphatase. These are tumor-associated antigens, and we've known about them, but that doesn't necessarily mean those are the immunodominant ones. So we're actually running a clinical trial that also will be opening here next month to help us identify the immunodominant neoantigens in patients.
Can you say a word or two about MD Anderson's commitment to immunotherapy? What is the sense there at MD Anderson in terms of the importance of immunotherapy in treating cancer, and what's being done to underscore that?
Yeah, so MD Anderson's commitment is probably one of the biggest that I've seen, and that's why I tumor immunology. And basically, he is spearheading what we call the immunotherapy platform, where it's not just the genitourinary malignancies or the melanomas, but every single disease that we treat here. The goal is to find immunotherapy strategies that will work, but also to find biomarkers that can help us predict who is going to benefit from the therapy ahead of time. So we're working in two different fronts to address these questions.
That's excellent. I think we have time for just one more question, and then we'll have to wrap up. Very interesting point. Do you think that checkpoint inhibitors will have the same effect on non-muscle invasive bladder tumors versus muscle invasive bladder tumors? Can you speak to that?
Yeah. I think not by itself, but maybe combined with the vaccine it will. And the reason why I say not by itself is because I think that cancers that are more genetically unstable, so the higher risk cancers, will have more neoantigens that the immune system will recognize. And something like superficial bladder cancer, which is not a highly aggressive type of cancer, will have less neoantigens. And so I don't think the checkpoint strategy alone will be sufficient, but I think in combination with a vaccine may be effective.
All right. Well, thank you again, Dr. Subudhi. That's all the time we have today for today's webinar. I do have a few closing statements to make. Again, I would like to thank our sponsor, Dendreon Corporation, for providing funding that made today's webinar presentation possible. Thank you. I'd also like to call your attention to two upcoming webinars we have. Next week, we have Developing Effective Immunotherapy for Ovarian Cancer and Other Tumors with Dr. George Kukos. And the week after, we have Dr. Glenn Dranoff on immunotherapy for lung cancer. A lot of very exciting things happening in both of those tumor types, and so we hope that you'll attend those webinars. Also, June is Cancer Immunotherapy Month, and that's why we are presenting this many webinars. We're doing 5 in the month of June for you as part of that celebration, in addition to the regular monthly webinars that we do. So you can learn more about Cancer Immunotherapy Month and all the activities that we have going on to raise awareness and to increase awareness of the need for continued funding of research in this area by going to cancerresearch.org/join-the-movement. Also, I'd like to let you know about a new website that we launched on June 1st, also as part of Cancer Immunotherapy Month. It's called I'm the Answer to Cancer, and it's a patient and caregiver resource for those folks who are interested in learning more about immunotherapy. The site features stories told firsthand by patients who've been treated successfully with immunotherapy across a broad range of tumor types and a broad range of immunotherapeutic approaches. We also have some commentary from oncology nurses and doctors as well. So please check that out. And also there's resources on immunotherapy in general and how to find a clinical trial in case you or a loved one is interested in looking into options for treatment for various cancers. So once again, I'd like to thank Dr. Subudhi and all of you for attending. And we look forward to seeing those of you who want to join us again next week. Thank you very much.